All right. Well, welcome everyone. It's wonderful to see so many people here today for the latest installment of the Seniors for Social Action series of presentations on innovative ideas and improving policy options for older adults. So my name is Lauren Bates. Some of you know me, some of you do not. I'm the chair of the Ontario Caregiver Coalition, which is a partner organization of Seniors for Social Action. The Ontario Caregiver Coalition is the voice of Ontario's caregivers, a grassroots organization. We advocate for recognition, respect, and better supports for the millions of family members and friends and neighbors who provide unpaid care for their loved ones, contributing to lives of dignity and sustaining our health and social systems. So I'm really pleased to have been asked to moderate this discussion today. The OCC is really excited about Dr. Kelly's work, and we actually sit on the project advisory committee for that reason. So I personally am really looking forward to hearing Dr. Kelly's presentation. So we're going to be talking today about the concept of care poverty in Canada, a concept that's really new to Canada, but offers some great and important opportunities to better understand needs for change and to advocate for solutions. So really pleased to be able to introduce to you Dr. Christine Kelly. She's an internationally recognized expert on directly funded or self-managed home care programs in Canada. She's been an expert witness and consultant on human rights cases related to home care and disability supports. And she's also developed policy guidance for the World Health Organization to strengthen the frontline care workforce. She has put her PhD from the School of Canadian Studies at Carleton University and her Master of Arts from the Interdisciplinary Program in Disability Studies at the University of Manitoba to good use. More recently, we were all very pleased to see Dr. Kelly appointed to the National Seniors Council, which engages with seniors, stakeholders, and experts to provide advice to the Government of Canada on current and emerging issues. They certainly could not have chosen anyone better. So as with other presentations in this series, Dr. Kelly will be opening the conversation by providing us with a bit of a formal presentation on care poverty in Canada. And then afterwards, we're going to have an opportunity for questions and open conversation. And so with that, Dr. Kelly, I turn things over to you.
Thank you so much, Lauren, for that very kind introduction. And it's been a real pleasure working with both OCC and the Seniors for Social Action Ontario. So, Harry, we can put the slides up and I'll walk you through what we've been working on. So, this is a result of the study we've been doing here, and we've got a lot of authors on here, and I want to really highlight the contributions of the second author, Aslam, who's really led the analysis, and he's just been amazing to work with. So, I thought I'd point him out. We can go to the next slide. So I know that you're in Ontario, but I'm here on the original lands of the Anishinaabe, Innuwak, Assininuwak, Dakota, Aote, and Dene, and on the national homeland of the Red River Métis. I think it's really important to do these acknowledgements, and especially right now where we have so many folks are evacuated down here in Winnipeg, and our city looks quite different right now as there's people sort of all over the place. So it's important to remember where we work from and sort of acknowledge that. You can go to the next slide. So this is the background of the study, and I'm going to just tell you right now that this is the technical half of the study, and the second half that we're still in the middle of data collection on and will be a little more user-friendly. So the background is that there's sort of alarming rates of unmet home care needs. And so home care needs being when you need help to stay in your home and to not end up in residential care. There was an earlier study that found about 1/3 of Canadians who receive home care services don't have enough, don't have their needs met. But we're also interested in the people who aren't receiving services yet and sort of on the cusp of starting to need help. Unmet needs are very common and most are non-medical, and you'll see that as we get to the results about what that might mean. So it's not really the help with your wound dressing that people are having problems with, but more with the non-medical help around the house. The research rarely accounts for social support, and just basically our rationale is that Canada urgently needs to advance its understanding of how, where, and why physical and social support needs continue to go unmet in community and home care settings. We can go to the next slide. So this is the first time the concept of care poverty has been used in Canada. It comes from a Finnish group, and specifically Teppo Kroger is the author of this concept. He's trying to evolve this sort of flat understanding of unmet needs to really emphasize that when you don't have your care needs met, it's a really serious situation. It could be considered what he calls a form of care poverty. The other difference here between unmet needs is trying to highlight what structural issues could be causing the needs to go unmet. What policy changes, what's going on in the context that might explain why we have unmet needs among older people. It's basically situations of not enough care. You can go to the next slide. So the study, what we're doing is we've got two parts. The first part, which I'm presenting today, which again, I apologize, it's a bit more dense, but it's going to be sharing the care poverty rates, the population rates, and factors associated with care poverty in Canada using Statistics Canada data. So it's a quantitative stage. The second phase is interviews documenting the lived experiences of care poverty in Canada, trying to understand more in depth about what's going on. We're guided by an advisory group that's coordinated by Seniors for Social Action Ontario. It's been probably the best experience I've had with working with a community organization. People have been so engaged and really directly shaped what we've looked at in the data and also what we've been asking people out in the community. So I thought it was apt to present the findings here first. So this is the first time that this has been presented. We can go to the next slide. So these were our questions for this part. What is the prevalence of care poverty in Canada, and what factors are associated with care poverty? We can go to the next slide. Our methods, and again, I'm sorry that, well, there's probably some PhDs in the room that are going to appreciate this, and there's other people that'll just breeze by. So depending on where you're at, I'll do my best to explain this. So the next slide. We used the 2018 General Social Survey that was actually on caregiving and care receiving. So there's these surveys they run every few years on distinct social issues, and they're going to be running this one again, or they might be right now. You may have been called. So the results are going to be released in 2026 for the next round. But other years, they'll ask about other issues, like they did one on remote working. And so we're using the data from the one that was on caregiving and care receiving. It's nationally representative data, which is really great. So just the way that they do their recruitment and the randomization that they do to find people, make sure that it represents Canada. The study does exclude the territories, people living on reserves, and people living in institutions. So that would be prisons or long-term residential care. So those would be the limitations. So from the survey, we're only really interested in people who identify in some way that they need help around the house. So that turned out to be 4,102 people that we're looking at their answers from. We use bivariate analysis and multinomial logistic regression. You can see on the right, like how did we find those 4,000 people? Those are the questions that you'd be asked. So the first one is, during the past 12 months, did you need help or care for a long-term health condition or physical or mental disability? And if you said yes, you'd be in our pool. If you said no, because older people tend not to identify as having a disability, the survey actually knows that tendency and asks you, if you had said no to that first question, it would say, during the past 12 months, have you received help for problems related to aging? And so those groups don't overlap, but it's meant to catch that kind of common psychological tendency for older people not to identify as having a disability. So between those two responses, that's where we got our pool of people that we looked at. Okay, the next slide. So this is what we found. This is the first slide in here is just the big picture prevalence. So if you think that the whole circle is representing those 4,000 people, so people who need help with something or other or received help with whether it was disability or age related. And of those people, 72% are saying that they got enough help, they're not having any problems, they need help and they got enough help. There's no problem. 27% did not get enough help, or we say are experiencing care poverty. So, of that, there's two types. There's one group who are receiving some help, but not enough. And that in the literature is called relative care poverty. So, when you are receiving some help, whether it's from, importantly with care poverty, it can be from unpaid caregivers or it can be from paid caregivers. So, you're receiving some, but not enough. For absolute care poverty, you're not receiving any help at all. Now, it's about half and half, and we'll explain more about who those people are in that absolute because that can sound quite extreme when you think, wow, there's a lot of people who are not getting any help at all. The next slide. So this is because we couldn't put this in the regression model. For those who are technical, it was just too messing things up too much. But I know that the Canadian audience always wants to know the provincial information. So here you go. Um, but we will take this out when I present this to international audiences. So the rates vary, and so this is the total rate. It's more useful than looking at relative and absolute right now. So it's as low as 23, and in fact, in my in Manitoba and Quebec, where I'm in Manitoba right now, and then it's highest in British Columbia, Newfoundland, and Nova Scotia. So we have some theories about what's going on here. In Quebec and Manitoba, we have universal provision of services. So there's no income testing. You can just, if you need home care, you're eligible for home care. Where British Columbia and Newfoundland, and I'm not sure about the other high place, Nova Scotia, does have income testing. So that might explain that. We also have higher proportions of older people in Nova Scotia and Newfoundland. So that might be part of what's going on there. Okay, the next slide. I know people love to see what's going on in the provinces. Okay, this is prevalence, and I'll show you when we get to the regression model, you'll see which ones came out as significant. So these are just prevalence right now. So you'll see that 45% of those in absolute poverty were aged 45 to 64, so a bit younger than you might think. And people in relative care poverty were in the youngest age group, and you can see that both goes down as it goes as they get older. Okay, we can go to the next slide. So we also found this is a question that's used to look at mental health. And so there's different ways to do this, but this one was turning out to be the easiest to understand. So if you're asked on a daily basis, how would you rate your stress? And you can say not at all, or not very stressful, or a bit stressful. And so that goes up like that. And you can see that 42% of those in absolute care poverty reported a bit of stress, so sort of in the middle. And then you also see that where orange is it's hard to understand this relative stuff. So the people who are receiving some but not enough, this goes down as the stress levels go up, basically. Okay, the next slide. This is very expected. We see this in existing unmet needs literature that women are more likely, sort of in both categories, to experience not receiving enough help or any help at all. And then we have higher rates in relatives, so receiving some but not enough help. Okay, and the next slide. This it will make more sense on the regression table, but there's a very complex relationships between disability and care poverty because you would think, okay, well, is it because Are the people with the most severe disabilities experience the most unmet needs, that type of thing. But what you see there, if you look at the blue line, which is the relative, you see that it actually goes up based on severity. So that's what you might expect. They have more needs and they're higher rates of relative care poverty. But then there's this sort of U shape for absolute care poverty. And there's something maybe that we're starting to wonder, people with the lowest level of needs are more likely to sort of be falling through the cracks or not getting any supports at all. Okay, next slide. All right, this is our regression table for those who know what this is about. So, Harry, I think I have some animation on the slide to help pull out certain numbers. If you press the, yeah. So when you see a star, that means that it's significant, and the more stars, the more significant it is. So we did find that for absolute or not receiving any help at all, there was significance in this kind of working age. And this bared out in the model of the working age adults being more likely to one, I think we actually have an odds ratio about one, make sure I say the right number, 2.3 times lower risk of relative, or it's a higher risk of absolute care poverty. And then for over the age of 75, they have um, a 3 times lower risk for relatives. So what that means in like practical terms is that when you're older, you're sort of less likely to be falling through the cracks. You're more likely to be receiving some sort of help. Another thing to help you understand this table, if this is completely foreign to you, is if the number is less than 1, so this 0.38, that means that it's a negative association, where if it's more than 1, it's a positive, so more likely versus less likely. Um, the next one, Harry, I think the next anime, yeah. So then looking at whether you're born in or out of Canada, so this is also not too shocking, but if you're born outside of Canada, um, those born in Canada have a 1.79 times lower risk of experiencing care poverty, is how this works out. So you're less likely if you're born in Canada. Household size is another one. So if you live alone, you're going to be, see these numbers are positive above 1 and they're significant. So if you live alone, you're more likely to experience both relative and or absolute care poverty. So that makes sense. You're on your own. You don't have enough help. Okay, the next slide. Okay, you can highlight this one. So on this slide, we're just looking at the two areas around stress. And here you can see those who reported extremely stressful were actually 9 times more likely to experience relative care poverty. So you can picture it's actually don't really have a good explanation quite yet about why people who, I mean, maybe it's what comes first, but people who are more likely to be reporting high levels of stress are in relative rather than absolute. But that might again go to the severity of the disability, where if we are starting to think that it's more mild disabilities are um, more likely to be in that absolute, not getting any help at all if you have a mild disability. And that sort of makes sense when you just start to become disabled. Um, you might not be getting help yet, is sort of the idea. Okay, and so I think we can go to the next slide, actually, Harry. I'll get out of the weeds of all this. These last two slides are, again, we couldn't put this in the, as someone saying, I'm assuming these questions are asked to the patient, not the caregiver. Yes, that was that's the focus. That's the respondent pool. We were looking at people who needed care themselves. The survey instrument we used did allow for proxy reporting, but it wasn't actually used that often. So that's just sort of an interesting note. So this is we couldn't do this for absolute care poverty because they weren't asked about what they needed help with in the survey. That's sort of a limitations. So just for people who are receiving some help, we were able to kind of guess and determine what they needed help with based on what their answers to a series of questions. So in the informal category, you can see pretty high significance of people who are experiencing care poverty, not getting enough help with managing finances. That was a bit of a surprise. And also the category called help with anything else, which is just sort of a bucket of kind of a last answer, all of the above type answers. So we're wondering, our theory on this is, did these questions just not really fully capture the type of help that people need day to day? And next slide. And this would be the same questions, but about formal. So meaning, are you a paid care worker? And here we had um, people who were not getting enough help were actually more likely to be having support from a paid, emotional support from a paid worker. And nothing else came out as significant here. Okay, so what does this all mean? The last slide on this. Well, there is something that's emerging, if you can see through all the weeds there, about working age adults. So are they falling through the gaps? Is it just that your situation's changing as you're aging? You're not yet getting help for the things maybe you used to be able to mow your lawn, and now maybe it's time for you to get help. We're also really seeing this a little goes a long way kind of theory where based on the findings about daily stress, disability severity, so having mild disabilities being more likely to not having any help at all, it might be the situation where a little bit goes a long way. So getting a bit of help at the edges of life might make a huge difference for people's ability to stay where they are in a long-term kind of way. And then with the data we have, the structural factors are just difficult to determine. There's not really a great question. We can come up with theories, but um, we need to do further, like we're doing right now, qualitative or policy analysts to figure out what's going on or why these demographic numbers are showing up. And so that's sort of where we're at with this study. Some of the strengths are the data and the input from the community advisory group, and the weaknesses, of course, those exclusions are, and just using pre-existing data. We would have loved to tailor the questionnaire to really measure care poverty the way they did in Finland, but we had to just sort of do our best with what we had here in Canada. And the last thing I wanted to mention on the last slide um, is that we are still interviewing people to try to understand, to really get more of the story around what people are doing. And so we're looking for people who are 65 and older who need help with basically anything. And I think it's important that even if you just need a little bit of help, we really want to talk to you about how you're managing and what you're doing. We're especially looking for men right now. We've had a lot of women respond, people of lower economic backgrounds, people of color, and people living in rural communities. So if you want, you can contact Jens at U of M and we'll set you up with an interview. So that's everything. And I know it was really dense and I'm sorry, but that's what this stage is all about. It's about getting those numbers.
Well, thank you, Chrissy, very much for that presentation. And although you said, this is dense, I think there's lots of very meaty information there. And from my own experience working with caregivers, a lot of what you were touching on just really resonates with, you know, m- the what I hear from caregivers. So maybe it also is going to resonate with a lot of people here in this presentation. So we are now, ready to open up for comments and questions. So I will be monitoring the chat and we'll, put your question into the conversation that way if that's the best way for you to ask your question. Folks should also feel free to raise your hand. The best way to do that, since I can't see everybody, is to use the raise your hand button under the react button at the bottom of your Zoom screen. Opening it up, I see that we have a question here from Helen Cooper asking, how do these results compare with those in Finland?
We can't compare directly because they were able to run their own survey designed around this concept, which is like just feels so foreign that we couldn't do that here. That's not how it works in Canada. But some of the big picture things were similar. So about women being at greater risk and living alone. Um, there's a few things that we're still trying to figure out, as you can even hear with us talking. These results, we just finished them maybe a week ago, so we're still trying to sort it out as we write up the full paper. Um, the other problem I'm personally having is just what what's different about this approach when you do it in quantitative research than what we've been doing before for unmet needs, which is the existing model. And because we're not able to really determine the structural or the in-depth stuff from StatsCan data, in the end, it's looking quite similar to what we did, what people used to do on unmet needs. The other benefit, though, I guess, is that it does capture the unpaid caregiving sources of support and not just the paid. So that's maybe something that this is bringing, where before it would just look at paid sources of support. And I think like a lot of people need help and they don't necessarily have a formal service. They have a spouse or a neighbor or somebody helping out. So, yeah.
Yeah, and I guess I'd add to that, the stats are that 70% or 75% of all care that's provided is provided by family and friends. So that's a very significant source of support. And I see a comment to that effect in the chat that having the patient report may result in underreporting if they believe that their children can do it all.
Yeah. Actually, it's funny you bring that up, Judy. That's a big methodological debate around this topic about who should be providing the data. So I'm just of the tradition and training that I always want to hear from the person themselves. And that's just my background. Want to hear, I come from disability studies. So you want to hear from the older person or person with disability if you can. And if they're not able to, then the caregiver, because it's just a different filter. There can also be researcher on caregivers and their experiences and what they go through. And so it's just really important to talk to older people themselves about what they feel. But I think you're right. I also think it's partly why we don't have enough men, because I think they might even be having, lawn services and snow removal that they've hired. And they say, well, I don't need care. I just need someone to do my lawn. Just not seeing it in that framework, where I think women generally seem to be more comfortable talking about the help that they need as they get older.
So I see that Andrew has his hand up. Andrew, do you want to go ahead?
Thank you. Hi, Chrissy.
Hi, Andrew.
What was the most surprising finding that you had so far, and what do you think it explains or questions it raises?
I was definitely surprised, like when you hear absolute care poverty, which is a bit fussy, but this idea that there's people with needs and they're not getting met. And you think, wow, that's going to be a small number, because how long can you go without getting help? And seeing how big that number is getting me thinking about, oh, people just need a little bit of help. And they probably, this is from the interviews, so I can't say it's from this data, but in the interviews, we heard of a person considering going to long-term care, and she really just needed a little bit of house cleaning and home care and just a few little things, and she would have been fine in her house. Her house was accessible. So it's tough to really think about how close people are to making these major life changes when really they just need a little bit of help around the edges or to take the edge off. And the other surprising thing is what Trisha's pointing out in the comments is that the oldest people are actually having lower rates in both absolute and relative. So they're I think just as you get to that age, maybe you're less likely to fall through the cracks, and people will help you out, or maybe you'll get on the radar for formal services if that's what you need.
So, while we're waiting for other questions to pop up, I'll take advantage of my position and ask one of my own, which is I'm really interested to hear you talk a little bit more about what the benefits are of using a care poverty framework as opposed to an unmet needs framework. I understand from your comments that you couldn't really, it's more challenging to implement it in this study because of the limitations of the data, but where do you see this going?
Yeah, I'm curious because I am going to Finland in next week, and so I'm curious to present this there and have this discussion with some of the people who created it. But one of the big difference, there's kind of a few things. One of it is that it's supposed to look at formal and informal sources of support. I know we don't always use the word informal in Canada anymore, but basically paid home care versus your unpaid family and friends, where unmet needs typically is focused on your formal or paid home care services that are available. Then the other difference is this structural focus, but that's very difficult to do in population social survey data unless you design the survey yourself and you're collecting that. But in most cases, we're using data that someone else collected and designed, and we have no control over the questions. I wish that we did because the advisory committee was very good at making questions for the interviews. So I think we would have had some really good ideas there. Um, and then there's one study I read in Denmark that actually did this really, really well. And she showed how care poverty rates went up after this huge national change to their home care policy. But that's a longitudinal design. So right now we only really have one wave that we're using. So you can see that there's potential, but it definitely needs more thinking and just trying to figure out how to connect that structural side so it's not just describing the population, which is what we're doing here as our inaugural attempt, but to really get at the why to help intervene. Those province numbers too are probably showing something on the structure that it's not going to resonate outside of Canada. But in Canada, thinking about why are we seeing higher numbers in certain provinces might might give us a clue about something they're doing in their policy directions.
So yeah, just to, I guess one of the things I hear you saying is we almost need a shift in the way people understand this in order to get the data to understand it, right? So that we're not, this will help us ask better questions, essentially.
Yeah, that's a great way to put it. Yeah.
So Keith, I see you have your hand up.
I do. Is there any comments about loneliness? My own experience with older family members and people I mean, literally street people and people I've met around, and I also do Meals on Wheels on for community care Durham. Loneliness seems to be a huge thing, and it seems to cut across a lot of ages. And we also know, I think scientifically, that loneliness can kill you if you don't do some sort of thing. My older brother, who's 84, told me that he could go for 3 days without hearing a human voice. So I got him connected with his local community care program. He's now doing Meals on Wheels and driving seniors around, thoroughly out of, loneliness completely, and it's really worked well. Anything around loneliness?
That's a great point, and that is also something that this care poverty is trying to do. Whether we were able to do it is another question, but they look at your personal care needs, your needs of help around the house needs, and then your emotional needs, your sense of belonging, your social connections. The survey wasn't great for that, to be honest. We are asking a lot more about it in the interviews, but the survey asks basically, are you getting help with emotional support? It's not ideal. Um, the other data set that I sometimes think about, wonder if we should have used, but the Canadian Longitudinal Study on Aging has a really great section on loneliness and social isolation. So I think it's definitely important. And I think you're on to something, but it's not well captured in what we've found, other than the kind of one finding around people in relative care poverty were more likely to have emotional support services. So it's certainly a great direction for the future. And in our qualitative phase, it is a big emphasis, actually.
So
Thank you.
since you're referencing the qualitative phase in the interviews, it's a good time to throw into the mix. Grace had asked, for more information about setting up an interview and a bit more information about what you're looking for. So Grace asks, are you interested only in care poverty support or every senior, especially male?
So we're interested in any person over the age of 65 who can identify that they need help with something in daily life. And it could just be like we're saying around the edges of life, like maybe you're not driving anymore, or maybe you need full home care and you're getting help with your bath, but whatever, as long as you need some type of help, then we'd like to talk to you. And the advisory group has really given us a great direction on this, which is to try to look at people who are not in care poverty. They're doing great. They have care needs. They're thriving. And people who are in some form of care poverty, and try to really understand both what's helping people thrive and what is sort of helping people or kind of causing people to struggle. And so, and we definitely will come back and present the results of that when we're done. So it's anyone over the age of 65 who needs help in some way, whether or not you're getting it met. And it can be a little bit of help or a lot of help. And we'd be happy to talk to you.
So Donna has been waiting patiently with her hand up.
Hi, how are you?
Good.
Good. I put the question in the chat, but I was just wondering, is there anything in the works, whether federal or provincial, where they might give us a tax break or the Ministry of Health will provide us with care for in the home for like shoveling snow and cleaning and things like that? Do you know of anything?
I know the National Seniors Council is advocating for a number of financial benefits, but the minister's changed about, I think it's 4 times since I started. So I'm not sure if our work is landing just yet, but that's something that's circulating in those networks where they're trying to push at the federal level. And I don't know if Lauren knows of anything at the provincial or otherwise, but that's just recommendations that a council just advises, and it's up to the ministers to actually um, make action our recommendations, or they might choose not to. But that's the only thing I've heard, and so it's pretty nascent.
Yeah, it's great to have a tax break, but the problem is if you're dealing with financial difficulty, you got to wait till the end of the year to claim that versus having the money available on a monthly basis that you need these people.
So I am going to jump in here because one of the things that the Ontario Caregiver Coalition has really been advocating for is what we're calling the Ontario Caregiver Support Benefit, which would be a monthly allowance of $1,000 per month. It's modeled on programs that are available in Newfoundland and PEI, so not through the tax system, so that it can be monthly and accessible across a range of needs.
Oh, that'd be
So this has
great.
been a top priority for us. And actually, last month in the Ontario Legislature, MPP, the NDP critic for long-term care and seniors issues, Wayne Gates, brought forward a motion in the House on that benefit, which was supported by all of the opposition, Liberals and Independents and Green Party. So again, we would need the actual government to take that up, but there is some momentum around this idea of putting cash directly into the hands of families to address their care needs. I think that's a long push up the hill, Donna, but I think there's lots of people recognizing the needs. So I can't say I'm hopeful that something's going to happen in the next 6 months, but I am hopeful that something will happen, say, in the next 6 years.
Okay, I may not be around.
Yes. Yeah, but it is, and I will say there is a petition available right now if you're in Ontario, anyone in Ontario,
Yes.
for the Ontario Caregiver Support Benefit. So if that's something that interests you, you can sign that, right?
Okay.
So Judy has commented that one issue may be that if someone has any benefits to cover assistance, it's likely for nursing care only and not for help around the house.
Yeah, this is actually a huge, well, especially talking here to an advocacy group, like you're not eligible for a lot of services unless you need help with the activities of daily living. So that you need help with bathing, eating, dressing, those really core activities. But most people need help with those things that are not that personal. So your shopping or maybe transportation, and that definitely falls outside of a lot of health service provision. So there's something there in terms of I don't think we don't need PSWs doing those types of jobs when we have such a shortage, but there's something about a gap there that we could work on better filling with our social services.
And then there's a follow-up to the question about loneliness. So Helen comments that the question about loneliness is very interesting. Why I asked about the results for Finland is that Finland is often rated as the happiest country in the world, and Canada is several notches below. And it seems to me that there's underlying social factors between our two countries that may be skewing these results.
Yeah, and I'm just pulling out this book here, but it has the rates, like, so if our rate is 27% is what we found in our study, the rates vary widely. Like there's some as low as kind of 9%. That's an American study, and then here's one that's as high as 58% in Germany. So I think it depends. This is the problem with like an emerging concept is we're all using it a bit differently. There's different contexts. And it's still very much in development, and we're adding to that with our study to help kind of clarify and figure out if we're going to be able to use this as an international comparison. But the rates vary widely. I mean, the highest I see here, but that's a very sketchy study, but there's a one rate of 61% of people in the relative personal care poverty. So it's a very specific type. Anyway. So it varies. I think that what I'm trying to say is I certainly think that there's a context difference between Canada and Finland that should show up in our numbers, but we're not yet using methods similarly enough. It's more of an orienting framework at this point. We're not able to use the same exact way of doing it to be able to do that direct comparison that would be so useful for us to say what the rate is in Finland versus Canada. But we have to just put so many caveats on it right now. It's almost not completely possible, other than more theoretically, we can talk about it.
So Trish has put an interesting question into the chat. Oh, wait, sorry, something is just scrolled. I think there's just a whole bunch of, sorry. Okay. So whether there's a generational difference in terms of perspectives of needing care. So, for example, people from older generations, wanting to see themselves as managing on their own and not seeing themselves as needing care.
Yeah, that's hard to say. I mean, we found higher rates around among the working age people. So is it because they're more like, I mean, you can always question the survey, which is we have to just sort of take the data we have, but are they not answering the questions the same generationally? There's no way for us to know. I mean, StatsCan does do very rigorous testing of their questions, so we have some confidence that that's been through a focus group more than once before they run it as a big national survey. But um, so we try to trust what the numbers they give us, but it's possible that younger people were asking differently. The only other evidence I have that might go against that is that there was another study done on people with intellectual disabilities specifically, and they found the same thing of higher rates among, they didn't use care poverty, but higher rates of unmet needs among the working age people. So there's something about that age and whether it's that it's new, it's an acquired disability, or that your needs are changing, or that you just haven't thought to go and get help yet. That's kind of what the running theory is.
So Frances has her hand up.
So fantastic presentation. Loved it. I just wanted to ask if you've heard of something called balance of care. Have you heard of that framework? It's out of the UK and it was used in Ontario. And it looked at people that were on the long-term care home wait list at a point in time. And what we found that when we had people from across the spectrum, I was part of that research, we had people that were from community all the way through to hospital and long-term care. And if we were able to create a care package based on what was actually literally available from the basket of services in Ontario and added in those preventative services that you're saying, we could see anywhere from a 20 to 50% diversion rate off of a long-term care wait list. So your research really resonates. It's not always the really extreme acute and chronic illnesses. It's often the snow shoveling that somebody put in the chat. So anyways, just wanted to say great job and hope that you're able to tie in more of those other pieces to really strengthen the case for the need for preventative upstream services.
Yeah, thank you. That's great. I have read that study and I used it in other work, and I think it's a good place to bring it in here. This kind of the idea that the person in the community, like the imaginary person in the community, might have a similar, often has a very similar profile to someone who's actually admitted to residential long-term care, and just. I mean, the government also really loves cost saving arguments, and that's a very easy one where you're like, wow, if we just had sort of $200 of snow removal, you would save just hundreds of thousands of dollars in the institution. So there's definitely something around this idea of like a little bit goes a long way. That's sort of what I keep thinking is we just need for people to stay at home, they just need a little bit of help. And it's what people want. I mean, we all know that. I think this organization's been just remarkably clear on the messaging around that because sometimes you can lose that messaging in some of the political documents where long-term care is so dominant. So just to like that reminder of if this is what we're actually trying to do, what does it look like? What would we need? Somebody wants the reference to that study in the chat. We'd have to look, I'd have to look it up, but or maybe you have it handy.
So I see that Trish has commented that, on the tremendous popularity of naturally occurring retirement communities, which allow older people to organize themselves and might seem to address the some care needs group.
Yeah, and actually, this is just a sneak preview, and I don't want to overstate because we're still in data collection, but in the qualitative, we are observing that the people who are thriving are proactive. So they make a big move, they renovate their house, they go to an apartment or sort of one of these communities that is basically a retirement community without formally being one. And some, I haven't met anyone in the study yet who's actually formally made like a co-op, like the full NORC, but there are some who kind of move to buildings that are more geared towards seniors, and then they do really well. Where the people who just sort of are in denial about what's happening, sometimes it's becomes too late, or a move becomes a bit too much or overwhelming, or there's a health crisis that happens and it's just not possible to move at that time. So there's something there about that preemptive move or really being realistic with yourself in your 70s and say, okay, what do we need to do? If I really want to stay and age at home, what do we need to do to the house or do we need to move at this point?
So Judy, you've got a question or a comment.
Yeah, I guess what I'm sort of poking at in my numerous questions, it seems to me, from my lived experience, is that perhaps why you're seeing the difference in the working age people's responses versus the older ones is seems like for a lot of people when they, and this goes to what you were just saying, Lauren, as well, if people leave the conversation too late, then they're almost afraid to ask for help because they're afraid of where it will take them. Right? So if you don't get your ducks in a row early-ish, then this fear sort of overcomes you that if you start asking for help, oh, you're going to get warehoused. Right? So I think maybe that explains some of it, perhaps. What do you think?
And so that maybe the younger people just haven't had their conversation yet, and then the people that we're seeing older have kind of had those conversations and got their support set up, and then I mean, you have to remember too that the oldest old in our sample would remove the people in long-term care. So that's another factor we have to sort of consider, but it's a small number of people in Canada in the end, but.
Thank
So
you.
you're just, yeah, thanks.
Sorry.
So you're just wondering if maybe the younger people just haven't had that conversation yet about it's time to get some help here.
Well, I think if you think that you're relatively well and you're relatively young, it's not so scary to ask for help. But I know, again, from people that I've helped, when they get to a certain point, they're afraid to ask for help because they're afraid of what that help might entail. And
Yeah,
that's why they're quite happy to lay it all on their family.
It's also like not just in this study, but in the studies I've done on self-managed care, the way that long-term residential care sort of shadows a lot of people's decision making. It's sort of looming over everyone as a place they don't want to go. So it's definitely there. And I do wonder too if like having it stifles our imagination as a society where you think, well, we don't really need to come up with great programs, especially for people living with dementia, because we always have long-term care. We don't. So there's something there about the way that it's there as the quote unquote safety net that nobody wants. It's sort of the safety net that we're all scared of.
Yeah.
So I see that Grace has asked, I think, a related question. And Grace, did you want to speak to this? You'd had your hand up or wanted to have your hand up, and we're a
Yeah,
little.
thank you. I know people try to stay at home as much as they can and get help in. But do you find then when they actually do really have to go to a facility, whether it's a senior's residence, that the move is actually then much more traumatic and more difficult, whereas if they are a little bit younger, they can get used to it?
We that wouldn't be in the survey, and even in the qualitative, because we're only talking to people in the community. I wouldn't know that part. Maybe someone else might have knowledge on that. Whether are you talking moving to a long-term care
Either
home?
there's assisted seniors living, or
Mm.
quite often long-term care will have a side, I'll call it a number of apartments that are not long-term care. They're more like retirement residents, and where there's more community where meals can be provided, and just what is the optimum time to make a move like that? Sometimes when you wait till you're in your 90s and you're really dealing with maybe dementia setting in, even though you're able to stay in your house all that up until your 90s. But then when the dementia sets in, then making any kind of change can be even more difficult, rather than if you had done it when you were like 85 or 82.
Yeah, I think just from the qualitative, which isn't finished yet, but we're just finding that people who sort of make the move, like sit down and decide, okay, I'm going to move to this apartment building that has doesn't have a lawn anymore, or I'm going to move closer. Some people were moving to a bigger city, things like that. Or there was one person who put an elevator in. No, no, we don't all have money for that. But this idea of proactively
Mhm.
facing aging and saying, if you really want to age at home, is your home set up for that? Um, I did speak to someone who was a lot older, and like there's just the move just there was no way, and they sort of needed to move, and it was just not going to be possible. And so then you do start looking at she kept saying, "Oh, there's no way I could do a move. There's no way I could do a move right now." So yeah, I think it's that proactive before you're in crisis. I mean, we know a lot of people, that's how they end up getting into services, is that you're actually something happens and you're in the hospital, and that's where you get your intake to more day-to-day help. So I think it's just we can sometimes be in denial about if you really want to age at home, then you have to think about it. What's your house set up like? And what if you couldn't do stairs at a certain point? Then what would you do? Do you have a washroom on the main floor? Is there an apartment like, and they're not all people are saying assisted living. Some of these moves were just to more kind of older friendly buildings and that naturally have a lot of social events and that dealing with that loneliness naturally have a lot of neighborly support because it's just this little community and it's not an official service. It's not anything like that. It's just kind of moving to a place where it had an exercise room and all that sort of, it was just an apartment building, but that's in a city setting. So of course there's differences.
Yeah, I think that is something that we could really stress. Like people talk about, aging in place, but that is not necessarily the place that you were when you were 55 years old. Like maybe, think when you're 70s or 80s, okay, maybe I should make a move, because then is the time. I'm dealing with my mother-in-law now who's 95, and she's, oh, her house was set up, but I mean, she's lonely and there's care coming in all the time, but still, she falls and then it takes a while before someone come, and to make a move now is just so difficult for her, where she had that in her mindset when we first broached it 10 years ago. She would have been able, but she was just, wouldn't. But I
It
think
may be too
generally,
premature, but I live in a bungalow now and I won't, I don't know, I'm very set on it. Whenever we talk about moving, I think, well, it has to be a bungalow. I know too much. So, yeah.
So I want to note that Frances has kindly dropped into the chat the studies that she was referencing. So I think this is there's a little explosion of conversation going on here now. So I'm just going to point to Kate had left a comment in the chat to the effect that essentially some of these proactive choices might be limited by financial wherewithal, right? That socioeconomic status can limit our choices. I want to recognize Jerry because Jerry's hand has been patiently up for some period of time. So, Jerry?
Um, Really, it's in support of the being proactive if you want to stay at home. I remember when I was thinking about moving from my house to a condo, and I had given myself the goal that I would be out of my house by the time I was 70. And I was amazed how many of my neighbors, when they finally found out I was moving, said, "Oh, I wish I'd done that myself, and now I'm too old." And one of the challenges I see is whether you're a person on your own making those decisions or whether you're a couple. I've had so many friends where one or other of them wants to move and the other one doesn't. So they just stay in sort of limbo in their current dwelling and then quickly fall into the group where they're too old to move. And the other comment I would like to make is bringing up very strongly this whole topic of loneliness and needing emotional support. I live in a busy social building, but I know there are people in my building who are lonely. And we don't really we'll get activities going, but we really don't, I think, in the formal sense or the informal sense, we don't make a lot of accommodation for helping lonely people or people that just would like a helping hand in that direction. I think it's a big problem.
Well, thank you. So those are some good examples of yeah, I can't get my own parents to move right now. I think I could get through to one, but not the other. So this idea that a couple might have different goals and then that overrides for some person. And the loneliness is huge. I mean, there's some people that's their whole research area, and I'm sort of after listening here, I sort of want to do some more reading in that because it does seem to be a core that falls outside a lot of these kind of typical policy responses or typical service responses. It's if that's your only need, if you just need some social engagement, it would certainly fall outside of a lot of formal help, at least informal help, not necessarily.
So Robin has asked whether you have any suggestions for promoting these conversations about taking proactive steps among younger generations.
How young are you talking, Rob? I think I'm sort of unusual that I'm already talking about it at my age, but I think it's like, they always say you should have the conversation with your parents about their will. I think it's more important to talk about their living arrangements and aging and when they're, if you yourself are in your early 70s, it's a great time to kind of think about this because everybody's so energetic at this age nowadays and it's hard because you've often been in the place you live for a long time, but but it'll be a lot more pleasant to choose where you go and kind of proactively make that decision and extend the amount of time or maybe be in the community forever if you make that choice when it's up to you and you're not in the hospital and having very limited choices about where you're going to end up. I mean, we even have a very young, she must be in her 30s, RA on this project who was injured and almost didn't get to go home because her house doesn't have stairs. So she was in an accident, and that was a big question about where she would be discharged to because her house wasn't accessible. So it's an important thing to consider that you might change and that you might not always be able to be as physical as you are.
Yeah, I would agree that working or being involved in this area makes you think about your choices quite differently at quite a young age. I was in my 40s when I started pestering my spouse about what our plan was going to be, because I could just see what happens when there's no plan, right? I'm like, well, we should think about. So, people thought that was a little odd, but I still think I was right. So, Frances has commented that seniors campuses are an option that she's seen work well for different needs um, along the continuum, right? And so it's a model that co-locates seniors' houses with long-term care and other services and supports. And then Trish comments back to that what is being heard from SSAO members is under no circumstances do they want to end up in a campus of care since they see it as a slippery slope to institutionalization. And so I don't know if you have any comments on on this back and forth, Chrissy?
Well, not based on this study, but I think that there's a lot of innovative ideas out there, and it's sort of I can see Trish's point. I can see both sides where sometimes I feel like I don't know if you've had this experience. You've been at a conference or something, and there's like some startup kind of guy, and he's like, "Oh, I know, we're just gonna make this building, and it's gonna have everything all in one, and we're gonna have." Our kitchen and you can and I'm like, you mean an institution? Like there is something where you can accidentally slide that way. And so I see what Trisha's saying, but I also see that people are trying to do different things with the campus or with the well, Norks is a great example, which is self-organized. That's a key difference. But this idea that there are people experimenting, and I mean, we're going to need all sorts of solutions. So the more that work and what works for you, and yeah, trying to choose it, try to choose it early, and it might even feel too early, but you'll look back and you'll say, "Oh, thank goodness I did that when I had the energy." And just that it wasn't such a big deal, or you didn't have a knee that you're recovering from a knee replacement. These types of things are really hard to imagine packing up and moving at that point. So, um, that's all I'll say about that. I can see what Trish means about the slippery slope, but I also think there's people really trying to come up with some solutions right now, and they look different for different people.
And perhaps it goes to your comment earlier about wanting to move the conversation away from just unmet needs to being able to look at the systems and the policy options, that is opening those up and having some better way of measuring what's actually going to meaningfully meet the needs of older people or younger people needing care. So are there other questions or comments? Oh, I see Frances has raised her hand.
So I'm going to talk from a personal point of view. A long time ago in a faraway land in the 90s, people may recall that home and community care used to be more cooperative than competitive, for example. And now we can't even get the home care we need because we can't recruit the health human resources that we need for the community. And so some people, just by lack, like when the balance of care was done up in the northwestern Ontario, there were people, to Trish's point, that had no business being in a long-term care home. And I think you mentioned, Kelly, about snow shoveling. So if they couldn't cut their own wood or chop their own wood, or if they couldn't make it to an appointment, say they needed dialysis, they had to go to a long-term care home in Thunder Bay, miles, kilometers, 200, 500 kilometers away from family. So the argument was made that, well, it's very hard. even in an urban center to get health human resources, how are we going to actually get those in northern rural communities? And so another area that may be of interest to folks is to look at what the Victorian Order of Nurses did in the Kingston region. They have a SMILE project. And so they used an attendant care type model that you might use with people with disabilities. And they were able to bring people in to take care of some of those smaller tasks like they used to allow with the veterans program. So there's no lack of imagination, and it's been 30 years that we've been talking about these things, and it's really nice to see people wanting to move the needle still. And I love that you're doing this research, and I hope it gets lots of attention.
And Trish points out that SSAO has had great success in getting the Ontario Health at Home program to provide needs-based home care. And referencing the mailing that was recently sent out around that. So that need for families, for caregivers to have strong advocacy skills. And Karen points out, oh my goodness, the chat is just exploding. I can hardly keep up with you folks. You have so many ideas. So Karen points to the Abbeyfield housing model as another one that addresses the unmet needs of seniors who want to age at home, but in a small communal setting that helps to address loneliness. And, Helen commenting on older adults who resist living in what they perceive as, quote, a ghetto for the age. So wanting to have more intergenerational exposure. I see the name on the screen is W. Peter. You have your hand up.
Oh yeah, Peter. Hi. Another problem is downsizing. It's a very difficult thing right now. The costs are very prohibitive when you're talking, land transfer tax and moving costs and real estate and on and on and on, right? And it's a really big problem because obviously it's not opening up those, sort of 4-bedroom homes and stuff for families that are coming in, whether immigrants or whatever. And the government's been talking about taking away the basic exemption on the principal residence, and that would almost be the end of downsizing. I think we're on a slippery slope right now where it's becoming, so cost prohibitive that it's very difficult. And without that principal exemption, I just literally could end the whole premise.
So really kind of taking us back again to both the idea of policy solutions, but also financial or socioeconomic barriers in the face of options that people might be interested in exploring. So are there other questions or comments that folks want to put to Christine? Okay. All right. Well, hearing no further questions or comments, it's been a very, very active and lively conversation. I think speaking to just the pertinence of the work that you're engaged in, Dr. Kelly, and its importance, I think, and really spurring people to think about the kind of change that could happen and what the needs are and what that could look like. So thank you so much for both your presentation and your engagement in this really important conversation. So as was mentioned in the chat, the slides will be available, as well as the recording of this presentation. I can imagine many people wanting to revisit this. It's just a deep mine of information. So thank you again, Chrissy, and I believe we can wrap up now.